Start for today's session. So, good morning, everyone, and I welcome you all to today's MRA Student Teacher Interface program. For today, we have Dr. Nayantara Shenoy, who is a first year DM resident from Bharati Vidyapit, Pune. She will be going to present a case, followed by a case discussion by our moderator, Dr. Salil Ganu, who is a senior consultant rheumatologist from Nagpur, who has expertise in managing complex rheumatic diseases, and this session will be followed by uh, uh, discussion on management of Apla syndrome, which is what is not taught in guidelines, which is taken by Dr. Ilyasul. So first we will begin with the case. So I'll over to Dr. Nayantara.
Good morning, respected faculty. I'll start with my case presentation. So, demographic details. This was a 42-year-old female, a beautician by occupation. She used to run her own parlor. Education is Masters in Arts and residence is Taluka Nivasa, Maharashtra. Her chief complaints started in 2025 with rash, joint pains, periorbital puffiness and pedal edema by July 2025, and abdominal distension with frothy urine by August of 2025. History of present illness. I'd like to start her history from April 2022 when she was 39 years of age, when she first presented with skin rash, oral ulcers, alopecia, and fever. So the skin rash started over the bridge of the nose and the malar area and above the eyebrows. It was painless and non-pruritic. Aggravating factors were sun exposure. It usually lasted for hours to days after sun exposure. And relieving factors were topical that were given by her local dermatologist. And negative history here, there was no muscle weakness or rash over the hands. And over the next 1 month, the rash had partially responded to treatment. She then developed an oral ulcer, which was over the palate. It started as a tiny isolated ulceration, which gradually increased in size as well as number. Over the next 1 month, it became confluent into a large palatal ulcer. It was, however, painless. There was no difficulty in eating spicy food, and it healed with scarring. It did not respond much to over-the-counter multivitamins, and there was no associated nasal ulcers. She then developed fever, but she did not notice any definite periodicity or diurnal variation. It was low grade, not associated with chills or rigors, associated with fatigue. There were no localizing symptoms, no cough, weight loss, or night sweats. By July 2022, she first started noticing localized portions of well-defined hair loss on the posterior scalp, which I've marked. Then she started noticing loss of clumps of hair on awakening in the morning. She would notice it on the pillow, as well as loss of hair clumps on combing. Over the next 1 to 2 months, she developed generalized hair loss with thinning and finally alopecia. There were no pigmentary changes that she noticed and no scarring that she noticed on the scalp. With topical treatment, it was partly reversible. She was evaluated for the same in 2022. She had first approached a dermatologist and was told to have a test called ANA, which was positive with low counts. She recollects that she was admitted and given steroid injections for 3 days and some oral medications. On these medications over the next 1 to 2 months, there was complete resolution of fever, oral ulcers, and skin rash, following which she was lost to follow up. In 2023, she recollects again one flare in which her skin rash and palatal ulcer recurred, but again she was admitted for 3 days and it responded to some steroid injections that she recollects with oral medications. By Jan of 2024, she developed new onset joint pains. This was insidious in onset, additive in nature, bilaterally symmetrical, and progressive, with gradual involvement of the small joints of the hand and feet as well as the large joints. There was sparing of the DIP joints as well as the axial skeleton. Associated was early morning stiffness of 1 hour with swelling, restriction in movement, difficulty in making a fist, and this affected her activities as a beautician. She remembers being offered a weekly once medication which she used to take on Sunday with a multivitamin that she used to take on 2 days of the week. She recollects that steroids were continued with some other oral medication and she had relief over the next 1 to 2 months, following which for the rest of 2024 it was uneventful and over the course of her illness she did not notice any deformities. By Jan of 2025, she now noticed again a recurrence of mucocutaneous lesions, but however, this was worse than her previous lesions. It was, however, in the same distribution. It was this time more erythematous and was persisting much longer. There was recurrence of the oral palatal ulcer, recurrence of the alopecia, recurrence of the pre-existing joint pains, and she recollects that at this point, the weekly once Sunday medication as well as the steroid dose was increased with partial relief. By July to August of 2025, she first noticed periorbital puffiness, which was more early in the morning on awakening, and she also recollects being told that her blood pressure was high and she was started on antihypertensives. Following this, she noticed pedal edema, which was initially just around the ankles. It was painless, it was bilaterally symmetrical. Over the course of time, over the next 1 to 2 months, it gradually increased to involve both the legs up to the knees and was consistent throughout the day with no positional or diurnal variation. Following this, she started noticing tightening of clothes around the abdomen and an increase in the abdominal girth. This was insidious in onset, gradually progressive, it was painless, and she also noticed froth in her urine. Over the next 1 to 2 months, this edema became generalized and she had a weight gain of 8 kgs over the next 2 months. As the abdominal distension also progressed to the present size, she developed discomfort in recumbent position. However, she did not require pillow elevation in the night and there was no exertional dyspnea. There was no history of decreased urine output or hematuria, no chest pain, exertional dyspnea, orthopnea, or PND. There was no history of jaundice, hematemesis, melena, or altered sensorium. There was no cold intolerance, hoarseness of voice, or increased somnolence. And there was no history of loose stools, weight loss, or bloating. Negative history. There was no history of oral or ocular injury or glandular
Nayantara,
injury.
can you just pause for a while?
Yes,
Uh,
yes.
yeah, I would request whoever is having your microphone on to please mute yourself. I think this is a basic courtesy when I think this is something that we all can comply to. Whenever a speaker is speaking, I think we can all cooperate with her. Please. I would request all of us, or maybe the person who is hosting this can mute all of us, and only whenever there's a doubt session or something, the host can allow the participants to unmute. I think that will be a better option. I mean, this is from a very personal experience where I take webinars, and this is a very constant happening. So
Yes,
I'm
sir.
so sorry, Dr. Nayantara, for this interruption.
Yes, sir.
I
Yeah,
think
Dr.
there is
Nayantara, you can. Yeah.
Yes, sir.
yeah.
Negative history. There was no history of oral or ocular sicca or glandular enlargement. There was no history of Raynaud's phenomena, skin tightening, digital ulcers, reflux symptoms, or difficulty swallowing. There was no history of proximal muscle weakness, nasal regurgitation, or dysphagia. There was no history of pleuritic chest pain or cough. There was no tingling, numbness over the extremities, no altered behavior, no headache, and no mood disturbances. Personal history. She had a mixed diet. Her bowel and bladder habits are normal. Her sleep was normal and no habits. Obstetric history. She attained menarche at the age of 15 years. Parity 2, living 2 with no abortions. There was no history of preeclampsia, eclampsia, or IUGR during both her pregnancies. Both were full term normal deliveries. The last childbirth was 11 years back and she attained menopause at the age of 40. Past history, she's a known case of hypothyroidism for 11 years and she's on Eltroxin 100 micrograms daily. Family history, her mother succumbed to coronary artery disease at the age of 70 years. Father is still healthy. There's no history of autoimmune disorder in the family. So just summarizing my timeline, patient presented with skin rash, fever and oral ulcers in April 2022. Alopecia by July to September of 2022. In 2023, she had one mucocutaneous flare. In 2024, she had new onset joint pains. In Jan of 2025, she had a recurrence of mucocutaneous symptoms as well as the joint symptoms. By July 2025, she developed periorbital puffiness with pedal edema, and by August to September, she developed abdominal distension with frothy urine. Treatment history with review of records. In 2022, she had received injection methylprednisolone pulse for 3 days followed by oral steroids, hydroxychloroquine, and azathioprine. In 2023, when she had a mucocutaneous flare, azathioprine dose was increased and she was again pulsed, now with a higher dose. Steroids were continued with HCQ. In Jan 2024, when she had her articular flare, methotrexate was initiated at 15 milligrams per week with folic acid, steroids, and hydroxychloroquine. July to August of 2025, methotrexate was stopped. The creatinine notice was 1.6. At this stage, mycophenolate mofetil was added, 2 grams per day with tacrolimus. Hydroxychloroquine and steroids were continued, and she was also on angiotensin receptor blockers. By September of 2025, there was Anasarca leukopenia mentioned in the documents with worsening renal parameters, creat of 1.9. At this point, the calcineurin inhibitor tacrolimus was stopped. The dose of mycophenolate mofetil was increased to 3 grams per day, and she was referred to us. So, summarizing my history, this is a 42-year-old lady with a 4-year history of multisystem involvement in the form of constitutional, that is, fever with no localizing symptoms, mucocutaneous manifestations in the form of malar rash, palatal ulcers, and alopecia, musculoskeletal domain in the form of inflammatory arthritis, hematological in the form of low counts, anasarca, and a clinical course that is characterized by flares and remissions. The differential diagnosis that I would like to consider first would be systemic lupus erythematosus. My second differential would be an overlap syndrome with rheumatoid arthritis in view of the predominant articular manifestations which were RA-like, symmetrical small joint involvement. The odd features was over the course of illness, almost 2 years, there were no deformities that she developed.
Okay. Uh, Dr. Salil, you want to ask any questions?
Yeah. So this tacrolimus was started when the patient had, and at the time of initiation of tacrolimus, the creatinine was 1.6, right?
Yes, sir.
And then it was continued under supervision, I suppose. But was it done
Yes.
before the patient came to you? I mean,
So we have
before the
creatinine.
patient reached yours and
Yes, sir. These were from review of
the tacrolimus
documents, sir.
previous documents. Okay.
Yes, sir.
And
Yes, sir.
yeah, the azathioprine was it started by the dermatology
No,
side?
sir.
Like,
No, sir. It was offered by a physician, sir.
okay, sure. Yeah, I
Uh,
think you can go ahead.
yeah, in the differential diagnosis, you put rheumatoid arthritis overlap, but
Yes.
still this can be only a plain SLE. I mean, there are no deformities as you mentioned. Then why you want to bring in the rheumatoid arthritis?
Yes, sir. Just considering a differential, sir, I just thought probably there's an overlap with rheumatoid, but as you mentioned, without
Mhm.
deformities, it's an odd feature.
Okay. And apart from, can it be any vasculitis?
So vasculitis can account for fever, it can account for arthritis, it can account for renal involvement, but the characteristic mucocutaneous manifestations of a palatal ulcer as well as the malar rash couldn't be explained by vasculitis, a primary vasculitis.
Okay. And what could be the other differential for palatal ulcer apart from SLE?
The other differentials for palatal ulcer could be traumatic. It could be also due to infections like herpes stomatitis, candidal stomatitis. It could be due to malignancies. It could be due to lichen planus. It could be also seen in the pemphigus disorders like pemphigus vulgaris or bullous pemphigoid.
Okay. And okay, so your case is very elaborative and making it toward systemic lupus erythematosus with the organ involvement of what exactly? Mucocutaneous, MSK, and
Constitutional
renal.
domain, renal
Really?
domain,
Yes. Okay.
lupus nephritis.
From the history part, can you guess ki what could be the renal involvement?
Sir, there was hypertension, no hematuria noted, frothy urine. So it is more like a glomerulonephritis, like a nephritis-like presentation. There was also edema, hypertension, and proteinuria as evidenced by frothy urine. So that would be more of a nephritic-like presentation.
Okay.
Or even
And
Arpesian, I would
this
say
will,
it would be.
RPG. Yes,
Yes, sir.
that. And do you feel does she have a cardiomyopathy? She's getting orthopnea and all.
Sir, so in cardiac illness, I would have expected the dyspnea to be at the onset as a very cardinal symptom. However, here she wasn't really dyspneic, and the discomfort and recurrent was as the ascites had progressed to her present size, which was, I'll come to the examination findings. It wasn't an initiating feature. There was no paroxysmal nocturnal dyspnea, there was no chest pain, there was no palpitations. So, cardiac causes would definitely be there in the differential, but lower down, sir.
Okay. And there is a question from the audience, Dr. Nemonil. He's asking where viral marker were done, hepatitis B, C, HIV, earlier if you have in the record.
Not earlier, sir, but we had done it, sir.
Okay. ठीक. Okay. We can proceed.
Okay. So on examination, general examination, she was moderately built. Her weight was 68 kgs. Her height was 159 centimeters. Her body mass index was 26.9. Her vitals pulse was 82 per minute, regular, normal volume and character, no radioradial or radiofemoral delay. Her respiratory rate was 19 per minute, thoraco-abdominal. Her blood pressure was 164 by 95 millimeters Hg in the right arm sitting position, and saturation was 99% on room air. She was pale. There was no icterus, cyanosis, clubbing, or lymphadenopathy. The JVP was not raised. There was facial puffiness. There was periorbital puffiness. There was pedal edema, which was bilateral, symmetrical, pitting in nature, both up to both the knees with very shiny skin. I will come to the image. Examination of the skin. She had maculopapular erythema over the bridge of the nose, the cheeks, above the left eyebrow, which was painless. There was sparing of the nasolabial fold. The scalp, there was generalized hair loss and thinning. Fragile hair was noted. It was a non-scarring alopecia. There were no plaques, no scales or dyspigmentation on the scalp, and no telangiectasia noted. Oral cavity, there were erythematous, superficial, palatal, painless erosions, 3 in number. Coming to the musculoskeletal examination, GALS, inspection, no deformities were noted, no previous scars, edema of the lower limbs were noted with Anasarca. Her gait was antalgic due to the knee pain and swelling. Spine, cervical, lateral flexion and lumbar flexion was normal, no supraspinatus hyperalgesia. Arms, she was able to outstretch her arms, and she was able to put her arms behind the head as well as the arms extended by the side of the body. On outstretching her arms, you could see that the fingers were swelling. The swelling was noted in multiple small joints of the hands. When the palms faced up, there was no thenar or hypothenar wasting. Patient had difficulty in making a full fist due to very florid synovitis. The grip strength and pincer grip was almost normal. MTP squeeze test was positive with a patient global of 8 on 10. Coming to the legs, the knee extension was normal. Hip and knee flexion, hip flexion was normal, but the knee terminal flexion was painful and not full range due to the pain and swelling. Hip internal rotation was normal. MTP squeeze was negative. Foot examination, the arch was preserved, though edema was present. There was no fixed flexion deformity of the toes or hallux valgus. There was no foot ulcer. So musculoskeletal TJC was 28 and SJC was 24. Systemic examination per abdomen. The abdomen was distended, flanks were full, umbilicus was transverse slit, skin striae was noted. There were no dilated veins. On palpation, the maximum girth of the abdomen at the level of the umbilicus was 104 centimeters. It was, however, non-tender. There was no guarding or rigidity. On percussion, shifting dullness was present. There was no fluid thrill. And on auscultation, bowel sounds were heard normally. Cardiovascular system on inspection, there were no visible pulsation, scars, apical impulse was not visible. Palpation, the apex beat was palpable in the left fifth intercostal space mid-clavicular line. There was no evidence of parasternal heave or diastolic shock. On auscultation, heart sounds were normal. There was no evidence of a loud P2 and no murmur. Respiratory system inspection was normal shape. Movements were bilaterally symmetrical. There were no scars or sinuses, no use of accessory muscles of respiration. Trachea appeared central. On palpation, chest expansion was 5 centimeter. Trachea was central. Movements were equal bilaterally, and the tactile vocal fremitus was normal. On percussion, it was a resonant node. On auscultation, the vocal resonance was normal. It was vesicular breath sounds with no added sounds. Neurologic, higher functions were normal. Cranial nerves were normal. Motor system, there was no focal neurological deficits. Sensory examination was normal. Reflexes were present and plantars were flexor. So, summary after my examination. Here we have a 42-year-old lady with multisystem involvement characterized by a relapsing remitting disease course involving mucocutaneous manifestations, non-deforming inflammatory arthritis, serositis in the form of ascites, hypertension, and anasarca, which could be due to the lupus nephritis. My diagnosis would be systemic lupus erythematosus with multi-organ manifestations in a flare and hypothyroidism.
Yes. Sorry, I probably missed it. Muscle power, did you test for
Yes,
her?
sir. The muscle power was normal, sir. There was no
Okay. Another
muscle power.
thing you showed the image of malar rash,
Yes, sir.
and you mentioned in history it was non-pruritic.
Yes,
So
sir.
how is it helpful? Can you explain?
So usually, so one of the differentials of a malar rash would be polymorphous light eruption, and that is extremely pruritic. Even the management would differ for both these conditions. So that is one condition that you would ask for pruritus.
Another thing is dermatomyositis and SLE. Is there any difference?
Yes, so in dermatomyositis, it would cross the nasolabial fold, whereas in SLE, it wouldn't cross the nasolabial fold because it would be in photosensitive areas. Also, if you look at the hands, you would have Gottron's sign that would be macular erythema with the PIP joints. In SLE, you would see the erythema between the MCP and the PIP joints.
Even the severity of pruritus, that is different between the two conditions. Okay, yeah.
And how is acne rosacea differentiated from malar rash of SLE?
In acne rosacea, most of the erythemas around the nose, there'll be a lot of telangiectasia. You could even have it could be mildly pruritic. It won't be as photosensitive as a malar rash of lupus, and you could also have scaling there. You could also have papules there.
Okay.
What are the
And
mucocutaneous manifestations of lupus? So, other than the malar rash, which is the acute rash, what are the other things which we can see in lupus?
So, ma'am, mucocutaneous manifestations by the Gilliam classification, you could do it as acute, subacute, chronic, that is lupus specific or lupus non-specific. The acute would be local, that is the malar rash. You could also have the generalized variety. In subacute, you could have annular or papillosquamous. And in chronic, you could have discoid lupus erythematosus or lichenoid DLE, mucosal DLE. You can have lupus timidus, lupus paniculitis, chilblain lupus, and non-specific lesions would be Raynaud's phenomena, erythromelalgia, lividoreticularis-like lesions, vasculitis, that is leukocytovasculitic-like lesions, um, thrombophlebitis. These would be lupus non-specific lesions, ma'am.
Yeah. So one more thing, like when a patient comes to us in OPD and tells us that there is a photosensitivity. So a lot of fair-skinned patients do get erythema when they go out in sun. That does not necessarily indicate a photosensitivity. How is it that clinically these two things are different? Like, is there any simple question that we can ask?
So one is the duration, sir. So classically, like in PMLE, there's a phenomenon called hardening where the patient continues sun exposure, it actually reduces. But in case of classic lupus flares with malar rash, this rash would persist for days, associated with burning, and may not respond and will persist even after the sun exposure is avoided.
It's
And you
generally said that if
yeah.
a patient is, patient's erythema is going away within half an hour, that is not likely to be, no, it is likely to be a normal thing.
Yes,
If
sir.
it is persisting beyond half an hour once the patient is out of sun exposure, that usually indicates an abnormality.
Yes, sir.
uh, apart from your patient has significant ascites and possibly glomerulonephritis. So how often do you see ascites in patient with SLE? I mean, usually serositis have pleural effusion, but which is missing, or the pericardial effusion, which is missing in your case. So do you think the patient has also a GI involvement?
So the GI cause for this amount of ascites could be either if she's developed an autoimmune hepatitis with cirrhosis of liver, but there were no other features of a chronic liver disease. Second, if there's a protein-losing enteropathy, that would be a pure GI cause for ascites. However, she did not have diarrhea, she did not have weight loss, which is why I didn't consider these causes. Third, you could also think of a Budd Chiari, that is a pure abdominal cause for the ascites. However, this ascites was not painful. There was no tender hepatomegaly. These were features that were against a Budd Chiari.
Okay. Okay. Yes, you can continue.
So coming to my investigations, on CBC, there was a normocytic normochromic anemia of 9.9 with leukopenia of 3,700, lymphopenia of 630, thrombocytopenia of 1.4 lakhs. DCT as well as ICT was negative and the reticulocyte count was normal. Both ESR and CRP, the inflammatory markers were raised. ESR was 98 and CRP 10. Creatinine was 1.6 with an EGFR around 40 and blood urea was normal. Liver function test, albumin was low, 2. Globulins were raised, 4. Alkaline phosphatase was normal. Urine routine showed protein 2 plus, white blood cells of 10 to 12, RBC 6 to 8. However, there were no dysmorphic casts. No dysmorphic RBCs, no CAS, and the urine culture was sterile. 24-hour urine protein was 8.5 grams. ECG was a normal sinus rhythm with no abnormalities. Echo had a concentric LVH, grade 1 diastolic dysfunction, mild pulmonary artery hypertension with a PASP of 32 millimeters Hg and a thin rim of pericardial fluid. On ultrasound abdomen and pelvis with a portal vein Doppler, the kidneys were bulky, increased echogenicity, CMD was normal, ascites was noted, the portal vein was normal, liver and spleen size were normal size with echo texture, and there was minimal bilateral pleural effusion. On chest X-ray, there was a blunting of the left CP angle with no cardiomegaly. ANA by immunofluorescence was nuclear fine speckled AC4 in a titer of 1:160. The rheumatoid factor was positive, 56. ACCP was negative. Complements were low. C3 was 55, C4 was 7.7, and the blot had Smith 2 plus and anti-RNP Smith 2 plus. dsDNA was positive at a titer of 600. Thyroid functions were normal and viral serology was also negative. Coming to the ascitic tab, grossly it was a clear straw-colored fluid. The total count was just 70, lymphocytic predominant. Glucose was normal, albumin was low, LDH was 32. It was transudative, that is, it was a high SAG, low protein ascites. SAG was 2.4, ascitic protein was 0.40, cytology was negative, AFP was negative, gram stain and cultures were negative. We also proceeded with a renal biopsy. It had 19 glomeruli and the diagnosis was class 3 lupus nephritis, that is focal proliferative lupus nephritis. The activity index was 6 on 24 and the chronicity index was 4 on 12. So my final diagnosis now would be systemic lupus erythematosus with constitutional domain, that is fever, mucocutaneous domain, that is acute cutaneous lupus erythematosus, mala rash, the non-scarring alopecia, palatal ulcers, musculoskeletal, that is non-deforming inflammatory polyarthritis. Hematological manifestations were leukopenia, lymphopenia, thrombocytopenia, serositis was there, ascites, thin rim of pericardial fluid, and just a blunting of the left CP angle on the X-ray. Lupus nephritis, that is biopsy proven, class 3, with an activity index of 6 on 24 and chronicity index of 4 on 12, and the SLEDAI 2K score was 26.
So there's one question there. What is the Dusseldorf classification of CLE? And what
Sorry,
is the
sir?
intermediate CLE? There is one question there in question boxes.
Yeah.
Dusseldorf classification of CLE and what is the intermediate CLE?
That is chronic lupus erythematosus, sir.
Chronic lupus erythematosus.
So, chronic lupus erythematosus, the most common variety is the discoid lupus erythematosus, which can be localized or generalized, that is above the neck or below the neck. Or you can have lichenoid DLE, in which you have DLE plus lichen planus. You can have mucosal DLE, which affects the vermilion border of the lip. You can have lupus tumidus, that is usually affecting the zygomatic area of the face. You can have lupus paniculitis, which is a lobular paniculitis and one of the few paniculitis that affects the upper part of the body. You can have chilblain lupus, that is violaceous erythematous rash at the tip of the fingers on cold exposure and could even persist without cold. I think that
So
comes
Doctor,
into chronic
have
lupus.
you heard about this classification name, Dusseldorf?
No, sir, I haven't, sir.
Achha, okay. So that basically classify cutaneous lupus into the acute, subacute, chronic, and intermediate lupus. That is the one who is asking about the question. Okay,
Okay, sir.
and there are few more questions. Ascites high sag, hypoalbuminemia induced, probably cirrhosis will cause this. Can Pagelma syndrome be considered as a DD here as ascites is predominant in cirrhosis?
Which
Any
syndrome, sir?
Pagelma syndrome, even I'm not completely aware.
I'm not aware of the syndrome, sir.
Anyone want to throw any light?
Any comment? And I also am not aware of it.
Uh, Hello, I'm Dr. Ilyas. It's Jalma syndrome.
Yeah. Okay, yeah, Dr. Ilas. You can
Jalma syndrome is basically in SLE we can get the ascites, pleural effusion, and elevated CA125 level, especially in young ladies, reproductive age ladies. So one of the DD is Jalma syndrome. It is one of the manifestation of SLE.
okay, but does it? I mean, does it have any relation with cancer or anything?
No,
CA125
no,
or
no, 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 no.
it's
It's
just a part
actually
of it?
CA125 is elevated without any ovarian cancer.
Okay.
It is like pseudo mix
It's like
syndrome.
pseudo
Pseudo
mix.
mix. Yeah.
Yeah.
He's talking about pseudomix. Yeah.
Yeah. I got it. Yes, sir.
Yes.
Okay, and
Okay.
ठीक है.
So
Anyone
the
want to ask?
management part, what would you have, what would, your, I mean, I understand the patient has come to a little late. It was treated elsewhere before this. So would there be anything else that you would have done? Like treatment part, would you like to change anything if it had come to you first, patient?
Sir, I would have evaluated. Actually, by Jan itself, she started having a flare of the disease, and this is the third time she's had a flare with increasing mucocutaneous articular manifestations. So at this point, I'd have been a little more aggressive, and I would have looked for lupus nephritis at this point of time itself. I would have looked for hypertension, proteinuria, quantified it, and if there was lupus nephritis, then I would have treated it more aggressively. I would have given pulse. I would have a pulse and then followed by zero point 0.5 milligram per kg body weight for at least 4 weeks and then tapered it. And the options that would have been there would have been either cyclophosphamide or MMF. But however, with such a predominant articular manifestations, probably cyclo and MMF would not have covered the articular manifestations. So the other option that I would have considered would have been rituximab, sir.
Yeah. So what is the usual timing of renal involvement in SLE? Like, is there any time period like that? Once you diagnose a lupus, or once you start getting symptoms, is there any particular time period between which we should screen more aggressively for?
So, lupus nephritis has to be seen early in the course of the disease. So, usually in the first 1 to 3 years, you would start screening for lupus. In fact, baseline itself for urine should always be done on follow-up, and you look for proteins, sediments, casts at regular intervals.
Yes. And then, I mean, the further course you are going to describe in.
Yes, sir.
Okay.
Yes, sir. So, treatment strategy. So,
Before,
actually,
sir, I'm so sorry.
yes,
Before you enter the treatment, if I'm not wrong, Dr. Nayantara, you had mentioned about the ascitic tap, and the ascitic tap had revealed a high SAG and a low protein ascites. Is that what you
yes,
had
sir.
mentioned, if I'm not
Yes,
wrong?
sir. Yes, sir.
And then the differentials, when we were trying to talk about the presence of an ascites in SLE, we were talking about what can be the possible causes of an ascites in SLE, and we were considering one of the differentials to be Budd Chiari, but then we found that there was no hepatomegaly. Nephrotic syndrome would have been one of the causes, considering her frothy urine, but
Yes,
then nephrotic syndrome usually would come with a low SAG ascites. It would not come with a high SAG ascites,
true, sir.
right? So, could you find out what could have been the possible cause of a high SAG, low protein ascites? Because one of the reasons that I, might consider, sir, I would like need you to also opine on this, and also Ilyas, sir, that maybe this patient, how long was this patient on azathioprine? If you can just uh, like uh, Like, remind me of.
Yes, sir. The patient was an azathioprine in 2022, 2023.
Okay. So, do you think azathioprine, can lead to this can lead to this high SAG low protein ascites? There is something which we call as nodular regenerative hyperplasia that we find in these patients. Because I found quite a lot of patients of SLE on azathioprine coming with this. They have patients. They have features of portal hypertension. They have splenomegaly. They have the liver functions are initially very preserved, but they have a high SAG and a low protein ascites. So would you like to think on that? And because the other thing that comes with a high SAG low protein ascites is an early Budd-Chiari syndrome. Only an early Budd-Chiari syndrome, because the late Budd-Chiari syndrome comes with a high SAG high protein ascites. What would you want to opine on that part?
Yes, sir. In fact,
Budd-Chiari syndrome, for that screening was already done. I
yes,
suppose
sir.
Doppler was
Total
already
Doppler
done.
was done.
Yes, sir. So I'm just asking if azathioprine toxicity can lead to that nodular regenerative hyperplasia, and that can lead to the ascites rather than nephrotic syndrome causing this, because nephrotic syndrome would not lead to a high SAG ascites, sir, generally.
Yes, this was something that even we were considering, sir, and which is why we extensively worked her up, but we did not find. I don't have experience with nodular regenerative hyperplasia. The only other thing that I could have thought with azathioprine is pancreatitis, but that would again be an exudative effusion. It wouldn't have been a transudative effusion. But I don't have experience with nodular regenerative hyperplasia.
Okay, Phileas sir can maybe speak something on this, because I have experience of a few patients that we were seeing in my hospital, AIG, Asian Institute of Gastroenterology in Hyderabad, and I remember getting a few cases of nodular regenerative hyperplasia of patients on azathioprine. These patients, over quite a long period of time, although they were not on azathioprine for 2-3 years. I mean, that's not the time frame. They were on it for quite a longer time. I mean, at least 5-6 years, if I'm not wrong. But their liver functions were preserved, and what we found on the ascitic tab is a high SAG and a low protein ascites. I mean, definitely nephrotic syndrome, you would agree, is not going to lead me to a high SAG ascites. It would lead me to a lower SAG ascites, because nephrotic syndrome will not lead me to portal hypertension. So that is something that is still keeping me in the loop. That how did this patient develop portal hypertension? Because unless there is an obstruction that can be there with Budd-Chiari, and you have ruled out Budd-Chiari because there is no tender hepatomegaly, there is no, the Doppler is clear. I'm still trying to wonder, how did this patient develop an ascites? Because there has to be something that has been occluding the portal, circulation. So
You
either it
cannot
can be something.
you cannot
Yes,
entirely rule out Budd-Chiari with the Doppler. Even Doppler
Yes,
can be negative in early Budd-Chiari syndrome.
yes,
Maybe intrahepatic.
Yeah, you have to do further imaging if you have strong suspicion, and also especially if you have ISAG low protein. Usually nephrotic syndrome will cause a low SAG low protein, and in that
yes.
case, if you are getting ISAG, if you have to suspect either like any SBP is there or any diuretic use is there, it can alter the ascitic fluid biochemistry. But
Hmm.
usually it will cause high protein, not like ISAG. I don't
Hmm.
know.
Okay.
Yes, sir.
Let's,
Sure.
yeah, okay, we can.
So, treatment strategy, as she had flared on maximum tolerated dose of hydroxychloroquine, multiple immunosuppressants at adequate doses, including azathioprine, methotrexate, mycophenolate mofetil, and tacrolimus, she was offered methylprednisolone pulse for 5 days. The options considered were cyclophosphamide and rituximab. However, as the articular predominant manifestation was predominant and recurring, in a shared decision making with the patient, we induced her with rituximab 1 gram, 2 weeks later 1 gram, and continued the MMF. Oral steroids were 0.5 milligram per kg per day, which were tapered gradually. And she was also subsequently given the first maintenance dose. The non-immune therapy were antihypertensives, bone protection, calcium, and vitamin D. And coming to her present condition, there's complete resolution of mucocutaneous, resolution of alopecia, articular manifestations, ascites, and pedal edema. In terms of the lupus nephritis, at the onset was at 8.5 grams. At 3 months, she had achieved 25% reduction. At 6 months, though it had slightly increased, however, it was 50% reduction. So she had achieved partial renal remission. Complete renal remission we will check for in August, which would be at the completion of 1 year. She also has developed bilateral posterior subcapsular cataract, giving her a SLE damage index of 1.
How would you define a complete renal remission and a partial renal remission?
Ma'am, partial renal remission would be 25% reduction of the baseline proteinuria at 3 months, 50% reduction at 6 months, and a complete renal remission would be less than 500 to 700 milligrams per 24 hours at 12 months.
Okay.
Okay.
So, what are the latest recommendations? Recently, in 2000, after 2023, guidelines for lupus nephritis management have changed. So, what are the latest recommendations for starting? The combination of mycophenolate plus CNIs versus using cyclophosphamide.
Yes, sir. So, as per
So
the
have
latest.
they asked, basically what I'm trying to ask is, would they have they recommended using this combination in all patients, or there are some exceptions in any guidelines? Because this is a very recent and common discussion that's happening everywhere right now. That we should go for a combination therapy for all patients, or there is any subgroup where we should not.
So, as per the latest recommendations, what they're recommending is combination of MMF with calcineurin inhibitors, or MMF with belimumab, or belimumab plus cyclophosphamide, or with obinutuzumab. These recommendations are more for patients with adverse prognostic factors. If it is the first presentation of lupus nephritis with no adverse prognostic factors, MMF or low dose cyclophosphamide, that is the Eurolupus, may be considered. However, if there are adverse prognostic factors, falling GFR, rapid increase in the renal function tests, hypertension, crescentic nature, that is more than 50% of the glomeruli having crescentic, then I would be more aggressive with the management, where I would consider either the NIH protocol or combination therapy. But in the recommendation, most of the newer drugs are not available in India.
Yeah, so the thing is, in 2024, ACR had made a paradigm shift. They had advised to give this combination therapy in all patients, irrespective of risk. They have not mentioned anything about risk factors. But the next set of guidelines, 2025 EULAR guidelines, they did make that exception. They were saying if the disease is quite aggressive, you can use NIH regimen of cyclophosphamide in those patients, or you can even consider CD20 for refractory cases. So would this dual use be considered a refractory case? I think it was given only for 2 months or 3 months, I suppose.
Yes, sir. 2.5 months, sir.
So what is the, you already answered that, partial renal response and complete renal response. Anyway, it was progressing, so this was refractory. Yeah.
Yes, sir.
Yeah. Okay. So any comments from Dr. Neena and Dr. Salil regarding case presentation? We have to move to the our guest speaker lecture.
Yes, yes. And it's quite well presented. I think most of the things were covered, but yeah, the SAG part, yeah, that was an enigma actually. We couldn't reach a conclusion. Anything,
Yeah.
ma'am, from your
Yes,
side?
well presented, crisp, and almost everything got covered well.
Thank you, ma'am.
Yeah. And thank you, Dr. Nayantara. That was excellent presentation. You are currently as a first year DM resident.
Yes, sir.
Yeah, so that's a really a good presentation. Uh, now I want to invite our guest speaker for today's, Dr. Ilyasul. He is a consultant rheumatologist at Metro Hospital, Kerala. He's DM rheumatology from CMC Vellore, and he has been very active in teaching, uh, and has done uh, uh, great awareness on Twitter, I would say. He has very great post from medicine and as well as the rheumatology point of view. So I would invite Dr. Ilasul to present today's topic, Apla syndrome in daily practice, what the guidelines didn't tell us. So over to Dr. Ilasul.
Hi, am I audible?
Yes, yes, you are audible.
My screen is visible.
Yes,
Can you see the slide?
yes, yes.
Okay. Yeah, first of all, thank you, MRA organizing committee, to giving this opportunity to present this topic. It's one of my favorite topic, and we have many confusion regarding this topic. In daily practice, every day we can see some cases of APS or some suspected case of APS. So every time we will have some doubt regarding the management of this patient. So before going to this topic, I have one declaration. There are very limited evidence for many of the manifestation of APS. So it's the most common acquired thromophilia, and it causes up to 20% of recurrent miscarriage. And it is responsible for 1 in out of 5 strokes under 50 years of age. And up to 40% of patients with lupus have APL antibody, but not all get antiphospholipid syndrome. And this thrombotic event can happen in any vessel of any size. That is very important. So APS is more than what we think. It can present as asymptomatic, then thrombosis, both in artery and vein. And it can cause microthrombosis. And it can present as pregnancy morbidity. It can manifest with the different non-criteria manifestation, that is non-thrombotic manifestations. And the severe form is, it's CAPS. So from asymptomatic healthy individual to the full-blown antiphospholic syndrome, that is CAPS, we can get any of these variety in APS. So first of all, we have to understand that this is APS is an antibody-mediated disease. So the antibodies are itself pathogenic, and strictly speaking, without antibody there is no APS. So the tests to detect antiphospholipid are particularly important in the diagnosis and classification of patients with APS. So if you see some studies, even with the quiescent state in APS patient, the factor 10A generation is very high. It is actually equal to that produced by LPS. It is lipopolysaccharide procoagulant. So it's almost similar to that. So even in the quiescent state of APS, it is baseline it's prothrombotic. So the question is, how are they formed, these antibodies, and what are they doing, and how can we detect them for diagnosis? Because before going to the guideline and what guideline is not telling, we should know some basics aspect of antiphospholipid antibody syndrome. Then it will be very easy to understand. So we know this beta-2 glycoprotein 1. This is the main molecule in antiphospholipid syndrome, and it is also called apolipoprotein H. So normally it has some function, that is, it is an anticoagulant normally, and it will inhibit the clotting, and it clear apoptotic cell, it regulate complement, it will clear microbes and oxidized LDL, and it will protect placenta. That is an important thing. It is maintain the placental hemostasis normally. So what will happen in APS patient? There will be some genetic or immune susceptibility, and sometimes there will be a trigger like infection, inflammation, or some drugs or oxidative stress. So that will lead to the antibody formation against this beta-2 glycoprotein 1. It has normally a circular structure, and it has 5 domain 1, 2, 3, 4, 5. And normally it is in a circular shape, and when there is a trigger, it can open up, and this domain 1 can open up, and the antibody can form against this. This can happen in normal individual also. With the normal infection period, they can get this, but most of them are usually transient. But if you have an underlying genetic susceptibility, this can be permanent, and it can lead to the persistent anti-beta 2 glycoprotein 1 antibody. So this two-hit model of APS is very important to understand. And so we know there are mainly three things in APS, that is two antibodies and one functional assay, that is anti-beta 2 glycoprotein 1, that will directly target beta 2 glycoprotein 1. And this beta 2 glycoprotein 1 normally bind to the cardiolipin, that is the phospholipid in the membrane. Normally it will come outside when there is a trigger. So when this beta 2 glycoprotein combined with the cardiolipin, this antibody is formed. This is called anticardiolipin. And the lack, that is lupus anticoagulant, is basically it's a functional assay. So if you can see, everything is similar, even though we are actually calling it as three different names, like anti-beta 2 glycoprotein 1 or anticardiolipin or lupus anticoagulant. Basically, everything is targeting this beta 2 glycoprotein 1. Even if you are seeing all these things actually targeting this, and sometimes one more antigen target is that is called prothrombin. So prothrombin also important. Usually it will bind to the phosphatidyl So anti-prothrombin or anti-phosphatidyl prothrombin is also important. So once they bind, what are they doing? So normal state, it normally when this beta 2 glycoprotein, it is bind to the phospholipid and it is cleared that apoptotic cell or microbe or oxidized LDL. But when this antibody is persistent, this antigen antibody can actually induce many receptors on the cell wall, like glycoprotein 1b, LRP8, annexin A2. So finally the outcome is it will increase the NF-kappa B production, and that will increase your tissue factor level and TNF level. So this is the simplest form of this coagulation pathway, where you will get extrinsic, intrinsic pathway that will join to form the common pathway, and finally you will get thrombus by conversion of fibrinogen to fibrin. So the measurement, you can see the extrinsic we are measured by APTT, and the intrinsic we are measured by PT, and the common pathway it is by this dilute Russell Viper venom test. So you can see one important thing. This all these green things that are phospholipid, all these tests or all these pathway require presence of phospholipid. So that's why if you have lupus anticoagulant is basically an antibody. So outside, that is in vitro, it's actually prolonging the clotting. Why? Because there are not enough phospholipid outside the lab. That is in the test tube, the presence of phospholipid is very limited. But in your body, in your blood, there are a lot of structure which is having phospholipid, like platelet, monocyte, endothelium. So it cannot prolong, it cannot cause bleeding in your system. Actually, it is triggering the cell to produce more tissue factor that will cause the generation of more factor 10 and then thrombus. That is why it is called a lupus anticoagulant is a misnomer. Outside it will be prolonged clotting and inside it will cause clotting. So how we can detect them for diagnosis, that is very important. Lupus anticoagulant, there is a screening test. Usually APTT is a screening test will be prolonged, then we will go with the confirmation. So we will confirm if it is a deficiency when we are mixing a normal plasma to the patient plasma, it should correct. But in case of lupus anticoagulant, it will not correct. And the main problem is this antiphospholipid. There is phospholipids are less because it is inhibited by your antibody. So if you are adding more and more phospholipids, like in the form of external phospholipid or platelet phospholipid, so it will correct this prolongation of your screening test. And if you take the ratio between the time in screening and time in the confirmatory test, if the ratio is more than 1.2, then you will call it as lupus anticoagulant is present. And if the ratio is more than 2, it means it's very high titer of lupus anticoagulant, and between 1.5 and 2, it is moderate. So the interpretation is very important. So even LA positive doesn't mean patient is having LA, because there are many cases you can get false positive lupus anticoagulant. I will come to that later. So One more thing you should know, there are other two tests also we usually do in CMC Vellore. One is anti-annexin 5 and other is anti-PSPT. They are actually important in obstetric APS. So don't confuse with the annexin A2 and annexin 5 because the annexin A2 is normally function as a fibrinolytic agent because it will stabilize your plasminogen and tissue plasminogen activator into the membrane that will activate plasmin and plasmin will cause this fibrin clot degradation. But what is happening in APS, there can be this anti-beta-2 glycoprotein antibody can bind to your annexin A2, it can displace annexin A2, so it can lead to the formation of more clot. Also, when the net result of this binding with anti-beta-2 glycoprotein 1 is prothrombotic state. So then what is the role of annexin 5? Annexin 5 is basically act as a shield on your membrane, your phospholipid or your endothelium or your platelet. So whenever there is this shield is there on phospholipid, the coagulation pathway will not activate. But in case of anti-annexin 5, if you have anti-annexin 5 or anti-beta-2 glycoprotein, what will happen? It can bind to this and it can displace it from your phospholipid layer that will activate thrombus. So basically, we have 5 set of tests. The two are extended tests like anti-annexin 5 and anti-PSPT along with your 3 classic things. So, this is ACR 2023 guideline. This is the simplest form of that guideline where you can see that for diagnosing, this is not diagnosis criteria, it's a classification criteria. But for classifying it into APS, you need 3 points from the clinical domain and 3 points from the lab domain. So the domains are, it's like venous, arterial, microvascular domain, and obstetric, and cardiac, and thrombocytopenia. And the lab things are like based on the tighter, it's different. So this is very important because this is one of the problem that we are facing in everyday practice. Because some labs, they are recommending it is ELISA. ELISA. This cutoff is for ELISA. That is moderate 40 to 79. It's basically based on the ELISA. So the problem is poor standardization of the test in APS. So ELISA is basically that they are recommending, and there are other methods like CLIA is there, chemiluminescent immunoassay, and multiplex technology is there, and immunodot-based assays. So the value given by all these tests are different, and we don't know what is the equal part with the corresponding ELISA. So this is the recommendation from this classification criteria. They are clearly telling about the LA that already I mentioned, and this solid phase assay for this anti-cardiolipin antibody and anti-beta-2 glycoprotein 1. So they are giving one rough estimate that if you are using CLIA, the value of 200 to 400 unit in CLIA and in MFI 700 to 2000 is almost equal to the value of 40 to 79 in ELISA. So there are some studies that try to standardize this multiple tests available. The one study is from Japan. They shown that they given some standardization for the available test. Like they actually did with this Innova, MBL, Thermo Fisher Biorad, and they put some value, but we don't know what test we are doing in India. Like multiple labs are doing multiple things, and the reagent, everything is actually different. So it's very difficult to standardize. That's one of the problem in India. So second thing is the pre-analytical factors affecting lupus antigen test. So usually when one patient is developing like deep vein thrombosis or pulmonary embolism, and so we are doing this test due to the acute phase of thrombosis that can raise two things, especially factor 8 and the C-reactive protein. So the rise in factor 8 can itself shorten APTT. It can cause false negative lupus anticoagulant if you are testing immediately after thrombosis. And the CRP do actually different things. So even if the CRP is elevated, the patient is getting DVT and secondary cellulitis, and you are doing your lupus anticoagulant, and the CRP may be very high, it can cause false positive lupus anticoagulant. So That's why people are recommending that you have to repeat the test after 3 months. Second thing is, so when you're getting a call from other department, they are suspecting the patient is having DVT and already started anticoagulation, and they send the test, and usually the report will come after 1 week. So what? So the LA may be positive or some other antibody will be positive, and they will call to rule out antiphospholipid syndrome. The problem is in anticoagulated patients, especially warfarin or heparin, this it's very important to read the test perfectly because in case of so usually you have to do the test if a patient is on warfarin or nasiprome, you have to consider testing 1 to 2 weeks after the discontinuation if feasible. In case of LMWHO, the sample ideally after 12 hours after the last dose and before next dose. And in case of DOAC, it can even this apixaban, levodoxam, it can itself cause false positive or false negative result. So if feasible, the test should perform only after 2 days after the DOAC interruption. And in case of pregnancy, the pregnancy itself interrupt this lupus antigen result. The false positive and false negative result may occur. So the repeat testing postpartum for reliable interpretation is very important, and the recommended timing is 6 weeks at least, or the ideal timing is these 12 weeks postpartum. So the thing is, if patient is on anticoagulation and you cannot stop the anticoagulation, what you will do? So that is important because if patient is on UFH or LMWH, in case of UFH, the LA testing can be performed while patient on treatment, and that LA test contains epipyranase enzyme or its polypyrene to neutralize the ultra heparin. And LMWH, usually it will not alter APTT that much because you can see that between the unfractionated heparin and low molecular weight heparin, this anti-10A activity and anti-2A activity is very important. For UFH, the activity is almost equal, that is 1:1. But in case of low molecular weight, this ratio is almost 4:1. So usually LMWH will not affect that much, but you have to perform at least after 12 hours after the last dose of LMWH. And in case of vitamin K antagonist, the test usually performed upon dilution of patient plasma with the normal plasma, not on undiluted plasma, because this other normal plasma can correct the deficiency that is created by the warfarin. And regarding the DOAC, the LA testing on undiluted plasma is not recommended, similar to the warfarin, but testing can be done upon removal of DOAC by absorbance. So the problem with there are many problems with the testing of this apply antibody. One is poor standardization. Second thing is anticoagulants interfere with the lupus anticoagulant testing, as I mentioned. And there can be transient positivity because of many triggers, especially the thrombus or pregnancy. And the low titer and isolated positivity, it's remain. We don't know the significance of this low titer and isolated positivity. And there is a need for repeat testing, that is after 12 weeks that you know. So you should, and there are one more thing is usually we will test IgG and IgM, but there are studies that showing that IgA antiphospholipid assay also very important in case of APS. So this is not standardized yet. So how to interpret all these tests? We have many tests. So how to interpret and its significance we don't know. So because we know only one thing: if the multiple positive things antibodies are there, it is very significant than single positive. I titer is significant than low titer, and IgG is more important than IgM. So there are some score like they can assess the significance of this antibody titer in APS. So one of this score is called the APL score, that is antiphospholipid score, where they are giving different score for each antibody based on IgG or IgM, even for functional assay they are giving. And using some equation, they are getting this antiphospholipid score. So what is the importance of this score is you can clearly see that if the score is more than or equal to 31, the cumulative incidence of thrombus is very high compared to less than or equal to 30. Even if it is 30, the difference you can see this, there is a huge difference between these two. So the cutoff is 31. If the APL score is more than or equal to 31, there is increased risk of thrombosis. And there are other than this, there are many scores in APS. So one more thing is based on each antibody, like in SLA patient, if LA is positive, the risk of venous thrombosis is odds ratio is 5.6, and for the anticardiolipin it is 2. For non-SLA patient, it is 11 and 1.5. And for ischemic strokes, it is a strong association with LA, that is almost 21 times. And ACL or antibiotic glycoprotein that also actually isolated finding can lead to the ischemic stroke. So one more thing is like multiplier effect is also very important in antiphospholipid syndrome, because the presence of lupus anticoagulation alone is only moderate risk, but if it is combined with the use of OCP or smoking, it can go up to 100 times. And the traditional cardiovascular risk factor is also very important if you have LA positivity. And we know this gap score, we know this because this score is like global APS score, and it integrates your cardiovascular risk and your lipid profile into this score. And based on the antibody profile and the other risk, cardiovascular risk factor, you can predict this thrombosis. Like there are basically dyslipidemia, hypertension, anticardiolipin, anti-beta-2-glycoprotein, anti-PSPAP. This is not there in your classification criteria, and it's a non-criteria antibody and lupus anticoagulation. You can see the maximum point is given to this anticardiolipin antibody. So higher the gap score, there is higher thrombosis risk. So what is mean by high risk antiphospholipid profile? So as per Euler update, they are telling if you have a lupus anticoagulant positivity, it's persistent, that is 12 weeks apart you are getting positivity, or it is triple APL positivity or double APL positivity or persistently high APL titer. So everything is considered as a high risk antiphospholipid profile. So coming to APS syndrome, so there are many unmet needs, like there are delayed diagnosis that is remain a major barrier in APS, and the current classification criteria fail to capture all APS phenotypes. It is not including the neurological manifestation like migraine, chorea, and other manifestation, and it is not involving the retinal manifestation. So even though the latest guideline, the classification criteria include this adrenal hemorrhage and other microvascular involvement like DAH, they didn't include this neurological manifestations and retinal manifestations. So next, other problems are like warfarin remains the cornerstone despite these monitoring challenges. So that is an important issue. So how to diagnose or how to suspect APS and how to detect this hidden APS, that is important. So because if somebody is doing APL and the APL is positive and we don't know significant, and you have to go there and find out the subclinical involvement if patient is not having any symptoms. And if patient is having the typical features of APS, then you have to find out the APL positivity. So when you have to test APL antibody, it's very important, because especially if patient less than 50 years, you are getting venous thromboembolism or an arterial event in less than 50 years, and retinal vascular disease, pregnancy complication, thrombocytopenia. And usually the thrombocytopenia is not that severe. It will be usually more than 30,000, and resistant chronic migraine case and skin manifestation like libido or ulcer. And in any systemic autoimmune disease, and the patient is planning for pregnancy, it's an indication to test APA. So the non-thrombotic manifestation and absence of concomitant systemic disease is the main thing that is lead to diagnostic delay. And up to 12% of the APS patient is having this microvascular manifestation. So we will miss many things like retinal involvement and neuro APS if you don't have a strong clinical suspicion. So this is again from this ACR EULAR 2023 classification again. So they include many of the things that was not in the Sapporo classification. like libido, pulmonary hemorrhage, myocardial involvement, DAH, and adrenal hemorrhage. So coming to this skin, because I want to talk what guideline is not telling. So we know up to 30% of the patient with APS having this libido reticularis or racemosa, and it can be the initial manifestation up to 40% of the cases. So it is usually associated with the arterial thrombosis, and if it is associated with Lagna's plug, it is called as Sneddon syndrome. And there will be painful ulcer around the medial malleolus, and the healing led to the characteristic porcelain white scar that is called atrophy blanche. And the other manifestations in skin are like APS ulcer and digital gangrene that are uncommon, but it's very important in management. So when you consider treating this patient with livedoid vasculopathy, so there are no proper guideline or recommendation, but what we are doing is like we can start with aspirin, then we can add pentoxifylline, and if it is resistant, you can go with anticoagulation. With there is one RCT with rivaroxaban that shows some promise. That is called the Relieva trial. That is rivaroxaban in lupus, this livedoid vasculopathy. They given 10 milligram BD dose, and later, once the ulcer healed, they reduced to OD dose. So that improved pain, erythema, and ulcer healing was there. So that is usually we'll go with the control of cardiovascular risk factor and the local management, and aspirin, then pentoxifylline, and you can go with this. So the APS and kidney, the one of the largest study with 1,000 patients with APS, it's shown that almost 3% is having APS nephropathy. So it can be different manifestation. It can be large vessel disease in the form of renal artery or vein thrombosis or renal infarction, or it can be small vessel occlusive disease that is called APS nephropathy, or it can be the initial manifestation of the CAPS. And the TMA also we know. So APS nephropathy, if you biopsy the kidney, you can get two types of lesion, acute lesion and chronic lesion. The acute is characterized by the thrombi, and the chronic lesion is characterized by the intimal hyperplasia and organized thrombi. So the clinical clue will be only resistant hypertension, proteinuria, hematuria, and CKD. And the urinary abnormalities in APS are not always seen, and the biopsy is usually required. And so this is one of the study where they looked into this renal manifestation in APS, and they find out there are three different clusters of APS and this renal manifestation in glyphosate antibody syndrome. The first cluster, they shown this thrombotic microangiopathy in biopsy, and cluster 2 shown this hyperplastic vasculopathy. Vessel wall was hyperplastic, and there was no thrombi. And the third cluster is like only some endothelial edema was there. So each cluster is associated with a different manifestation, and the very poor prognosis was associated with cluster 1, where this is associated with thrombosis, higher gap score, triple APL positivity, and worse renal outcome. And hyperplastic vasculopathy is associated with cerebrovascular events. So better prognosis is for the cluster 3. So if you see the classical lupus nephritis and APS nephropathy, the pathogenesis is entirely different. One is it is immune complex mediated disease with the complement activation that lead to this proliferative glomerular nephritis or crescent, where the management is basically immunosuppression. But in APS nephropathy, the basic thing is there is an involvement of vessel with thrombus. Even though there is complement activation is there, it's localized. So it's predominantly thrombus. So management is initially the anticoagulation, but in a refractory case, you can try immunosuppression, even though there is no proper guidelines are there. So severe disease, you can try steroids, plaques, IVIG, rituximab as like your caps. So regarding the DH, it's rare in primary APS, almost 2%, but more frequent in caps, that is almost 12%. So it is a very severe life-threatening manifestation of APS, and the management is like that is it's the largest cohort with 290 patients, where there's Mayo cohort of 61 patients, along with the systematic review of 158 cases. They shown that 30% patients are having SLE, and almost one third is developed CAPS. So it's the manifestation of CAPS in one third of case. So prior thrombosis history was almost there in 3/4 of the patient is having prior thrombosis. And the most important manifestation and most common manifestation was hemolysis. So you can clearly see that it's mortality, that is at 1 year, it is almost 30%, and it close to 50% at 5 years. So the risk factors, so when if a patient is APS, and what are the risk factors that is associated with this APS DAH? So triple positivity is having the hazard ratio of 4, and the male sex, high APL titer, and multiple vascular involvement. Everything is linked to DAH. And the left-sided valvular disease and hemolytic anemia that is independently predict the DAH. So coming to the myocardial disease, because why I am telling this microvascular first, because the guidelines are not there about these diseases. And the myocardial disease, so the MINOCA, if you're having STEMI or NSTEMI with normal coronary in angiogram, you should suspect APS in this patient. So there can be cardiac MRI abnormality like light gadolinium enhancement, T2 abnormality, and perfusion MRI abnormality. And if the biopsy is it's not feasible in India, but there can be small vessel cardiac thrombosis. So there are many evidence that linking MINOCA and APS. Multiple studies are pointing out that in patients with MINOCA, these APL antibodies are persistently positive. So if you are getting a MINOCA case, always send APS if there is no other risk factor or there is no vasospasm. So adrenal disease is like usually it is due to bilateral adrenal vein thrombosis that later lead to the hemorrhagic infarction, and it is a frequent manifestation of the catastrophic APS. And if in a patient with APS and loin pain or pelvic pain or lower abdominal pain, and there is no features of mesenteric ischemia, always suspect this adrenal hemorrhage in this patient. And the treatment is basically, this you have to replace steroid, and almost the prior studies and prior case report, almost 3/4 of the case they treated with anticoagulation. So the retinal disease are the most important thing because frequently missing manifestation of APS. It can be retinal arteritis, retinal artery or vein occlusion, ischemic optic neuropathy, amaurosis, or diplopia. So the key findings in fundoscopy will be this peripheral ischemic retinopathy. It will start from the periphery and it will go towards center. And there can be hemorrhages, vascular sheathing, and capillary non-perfusion with arterial leakage and maculopathy. So the fundus fluorescent angiography is very important in case of retinal involvement. And if your patient is not having any other risk factor, always send for APS antibody. So this we know neurological manifestation is called a neuro APS. It is not included in the this ACR 2023 classification criteria. But still, patient present with a stroke that is, even though it is thrombotic manifestation, there are other microvascular dysfunction that lead to many other manifestations other than stroke and TIA, like migraine, seizure, cognitive dysfunction, even transverse myelitis can happen, seizure also. So the migraine headache is basically it's a secondary headache in APS and usually seen in triple positive patient. They will show this abnormal MRI changes like white matter hyperintensities. And the disease duration, BMI, and triple positivity correlate with the headache severity. Sometimes, if the headache is refractory, you should suspect this ischemic stroke or also venous sinus thrombus. In a non-patient with frequent migraine, and if it is refractory headache and it is not going and changing character, always do imaging to rule out stroke or venous sinus thrombosis. So you can see this white matter hyperintensity in patient with the APS and the neurological manifestations. So now what we know, it is having complex pathogenesis. APS is having complex pathogenesis. It's a very heterogeneous disease, even though it's anti-mediated disease. And it has got both components. It can be thrombotic manifestations are there, inflammatory are there. So they are going together. And there are no proper RCTs, and the APL profile itself is heterogeneity, and there are multiple disease subsets like thrombotic, macrovascular, microvascular, known criteria, and pregnancy comorbidities. So these are the So there are many treatment challenges in patient with APS. So if you see the obstetric management, I'm going fast because we know almost these things what guideline is telling regarding obstetric management. So it's a risk factor for many adverse outcome in pregnancy for both mother and fetus. For mother, it is eclampsia and thrombosis, and for fetus, it is like a miscarriage or fetal death. So even though we are managing with aspirin, heparin, or other things, with the current treatment, the 80% of pregnancy only lead to live birth. Just 20% they are not going to live birth, and almost 40% patient is having preeclampsia during pregnancy, and 13% is having IUGR, and 30% is developing preterm delivery. So this antibody profile in obstetrics is very important because the maximum prevalence is for anticardiolipin, and the poor outcome is associated with the beta 2 glycoprotein 1 antibody. And more than one antibody, it will increase the risk. And the triple positive, the live birth is only in 30%. So if you have triple positive APS patient, and the chance of a live birth is 30%, despite low dose aspirin and prophylactic LNWH. So we know this. Why I'm telling this, this APL can affect early pregnancy or late pregnancy. Early pregnancy, it will inhibit the trophoblast migration that will lead to the failure of placentation. In the late pregnancy, it will lead to the failure of spiral artery remodeling that will cause placental insufficiency, preeclampsia, IUGR, fetal death, and everything. So we know the we are thinking that the heparin is basically antithrombotic effect in obstetric, but it is more than that. The role of antithrombotic effect is minor because this beta 2 glycoprotein actually bind with this positive charge of this heparin. So heparin can directly bind with this positive charge, the beta 2 glycoprotein 1 that is involved in the phospholipid binding. So that will decrease the this thrombotic manifestation, and it will heparin increase the placental expression of several molecules like BCL2, MM3, and heparin binding epidermal growth factors. That is actually improving the placental function and implantation. It will enhance the cleavage of binding site in beta 2 glycoprotein 1 that will reduce ability of this phospholipid to recognize beta 2 glycoprotein 1. And it is inhibiting complement also. So overall, this heparin is not only an anticoagulant in obstetric APS, it is having multiple other pleiotropic functions. So coming to the management of obstetric, this guideline, what guideline is telling, we can divide the patient into 4 groups. One with one pregnant lady with asymptomatic antiphospholipid positivity without prior history, and patient with obstetric APS, and patient with already having thrombotic APS, and the management of postpartum in all these patients. So regarding this asymptomatic antiphospholipid antibody, whether to treat or not, that is important. So there is an RCT of 1176 individual, and the general high risk pregnancy, like advanced stage smoking, hypertension, diabetes. So everybody is having the same thing, and aspirin lead to significantly lower incidence of preterm and preeclampsia in this trial. So ACR support use of low dose aspirin before 16 weeks of gestation among pregnant patients with APL positivity. And you will also recommend aspirin for women with high risk APL profile. That already I mentioned what is meant by high risk APL profile. So these are the evidence that is available to us, and this is a recommendation. And one more thing is that this British Society of Hematology in 2024, they also put some recommendation. So obstetric APS without thrombosis, if you see the evidence, there are 4 RCTs, and it's shown that higher live birth with the low dose and prophylactic heparin. And 2 RCTs, there is no difference between low dose aspirin alone versus low dose aspirin plus heparin. And the Cochrane review in 2020 shown that it's better to give low dose aspirin plus the prophylactic heparin for a good pregnancy outcome. And if patient is, so this is the EULA recommendation that is published in 2023, and we know this what to do. So all these cases we have to start low dose aspirin plus prophylactic dose heparin. You can see this level of evidence, and it's like basically, and grade of recommendation is 2B and B. It is very important. So all these patients require these things. This guideline is telling. So aspirin or heparin or both in the treatment of recurrent spontaneous abortion in women with APS. So it's a one meta-analysis of a randomized controlled trial. They have 19 publication with 1,200 patients. So aspirin plus heparin, they improved almost 23% increase in the live birth, and heparin alone only 18%. Aspirin alone is not improving anything. So that means that, so what we can get is the heparin is very important in the management. Second thing is the pregnancy with the history of prior thrombosis. So it's basically low dose aspirin and therapeutic dose. And the pregnancy itself is increase the risk of venous thrombosis by 6-fold. So the management is very crucial. And this is what EULAR is telling, like low dose aspirin plus therapeutic heparin. So this is guideline. So and this heparin, you should ideally, if patient is already on vitamin K agonist, that is warfarin and aceclomyelin, the ideally you should change to heparin before 6th week. Usually in that time only people will realize they are pregnant. So as early as possible you have to change, because between 6 and 16 weeks of pregnancy it is a critical period of fetal growth, and warfarin can cross the placenta during 6 and 16 weeks, and it can lead to the warfarin fetus syndrome. And despite this heparin and low dose aspirin, if patient is having a recurrent pregnancy complication, what are the other options we have? So this, even though the level of recommendation is 5 and the grade of recommendation is D, there are other things like we can increase, if patient is on a prophylactic dose of heparin, we have to increase to therapeutic dose. And we can add hydroxychloroquine, and there is a addition of low dose prednisone also. EULAR is recommending, but the ACR is not recommending. So we can see the evidence. What is this evidence? So HCQ, what is the evidence? So, so almost 148 refractory cases of this obstetric APS. They gave one group with HCQ 400 plus this low dose aspirin LNWH, another group only low dose aspirin plus LNWH. So they shown that in this HCQ group, the live born babies, like 97% is live born babies, and another group it is only 63%. And regarding the recommendation regarding this statin in case of refractory obstetric APS, there's a study on this pravastatin 20 milligram per day along with the low dose aspirin and LMWH. So this is the onset of preeclampsia or intrauterine growth restriction. So they have shown that the pravastatin group has increased blood flow, improvement in preeclampsia, and almost all deliveries are like full term. But in the control group, the only 6 out of 11 neonates survived. So again, even though it's a limited study, there is some benefit with statins. And if you see the treatment of a refractory poor APL patient, like a poor APL related obstetric APS with a TNF blocker. So this is the first this is a retrospective study, only 18 patients with the 12 complete obstetric APS and 6 incomplete obstetric APS. And they gave adalimumab in 16 patients, and 2 patients received certolizumab. And so the 70% outcome was good in refractory cases. That was evidence that is lead to the phase 2 trial of this certolizumab in that's called the impact trial, that is published in 2025. And this impact trial shown that if you are giving a certolizumab between week 8 and 28 of gestation, it is lead to good pregnancy outcome. That is 93% of the neonate survival to hospital discharge. So this is just a phase 2 trial that published recently. So in case of refractory thing, we can give certolizumab, and other TNFI prospective data are minimal actually. So regarding the low dose prednisolone, why EULAR is recommending, because of this study where they 18 women with the APLA and refractory pregnancy loss, they gave prednisolone at the 14 weeks up to the 14 weeks of gestation. So they compared it with historical control, that is before prednisolone. So in that 97 pregnancy, that is lead to only 4 live birth. But with the prednisolone, they got like 61%, that is 14 live birth. So based on this thing, that is historical control data with this study, the regular is recommending that is even though it is a D grade of recommendation. So there are new studies ongoing for HCQ, like one is hibiscus trial SCQ for secondary prevention of thrombotic and obstetric in primary APS, and hypatia trial is there. Again, pregnancy outcome. And hydrosapel, that is phase 2 RCT HCQ 400 plus standard of care in one with the primary APS and obstetric APS. So, and one more thing is regarding IVAG, there is very, very limited data on IVAG, and there is one 2005 study showing that it is not useful. But after that, one more study in 2003 showing that with a different effect with a different IVAG regime, like 2 gram per kg or 400 milligram per kg. So the dosing is we don't know. But the only thing they found that the late pregnancy complications are reduced, even though the live birth rate is statistically not significant. But EULA recommendation is like 5D level of evidence. So this is a summary of what I told, how to manage all these cases of obstetric ABS. And regarding the primary thrombosis, how much time I have?
Uh, 5 minutes maybe. I think we are 12:30, but you can have 5 minutes.
Yeah, I think almost if APL is positive, whether to give aspirin, statin, or hydroxychloroquine or vitamin antagonist. So aspirin is recommended only in high thrombotic profile or high risk APL profile. If patient is having APL positivity and cardiovascular risk factor or high risk APL profile, you can give aspirin as primary. And aspirin primary prevention, there are many trials that shown same thing only. And statin also, if patient is having additional cardiovascular risk. And hydroxychloroquine, if patient is having APL positivity with underlying systemic autoimmune disease like lupus, can give hydroxychloroquine. And I'm skipping this. Even there's a low dose of anticoagulation, there is no beneficial effect to prevent thrombosis in asymptomatic APL positive patient. The secondary thromboprophylaxis, we know DOAC and vitamin K antagonist, and whether it is a high intensity warfarin therapy or low intensity, there is no added advantage of high intensity warfarin therapy. That means INR of 3 to 4.5. And DOAC is basically, even though previously we had all the RCTs failed, and we usually tell even if it is single APL positivity, we can give. But the latest trials are showing that there is one systematic review was that published in 2025. It clearly shown that even with the single or double positive APLA, the incidence of arterial thrombosis is more. So it's better to avoid in all cases of antiphospholipid antibody syndrome, the DOAC. Again, the risk of this is a very important thing: risk of recurrent thrombosis. If patient is on a therapeutic dose of heparin or warfarin and INRs and target. So almost up to 4% of the patient can have recurrent thrombosis while on treatment. So how to manage this kind of patient is very important. Always look for subtherapeutic INR, low compliance, and patient education. And first thing is increase INR target to 3 to 4, addition of low dose aspirin, and switch to LNWH from warfarin. That is also important. And always exclude other causes of thrombosis if patient is refractory, like other thrombophilia and surgery, major trauma, and cardiovascular risk factor. And this is one case that is published in Blood. It's very interesting how they managed one patient refractory to all the treatment. So basically, they did initially they increased to INR 3.5, then they changed to LNWH. They increased LNWH to 20%, then 30% increase, and finally they gave on fondaparinux along with rituximab. So we can also follow the same thing if patient is.
Uh, Dr. Ilasul, your voice is not there. Hello. Uh, I think we lost connection. Try to check.
Can you hear me? Hello?
Yes, yes. Yes, we can hear you.
Yeah,
Yes.
give one more slide. This there.
Yeah.
So one word regarding this CAPS, because there is very less evidence on the management of CAPS. What we follow is heparin glucocorticoid plasma exchange or IVIG. And if there is improvement, we'll taper and stop glucocorticoid and long-term anticoagulant. That is the normal thing. And if it is relapsed, we can use B-cell depletion like rituximab or complement inhibition. So, concluding my talk, there are many real world challenges in the management of APS. And there is a diagnostic pitfall, the problem with the testing and the standardization. And finding hidden APS is also important. And you have close suspicion for hidden APS. And the lab reality also, the repeat testing after 12 weeks. Everything is important and it's a challenging also. And regarding management issues, this warfarin monitoring and warfarin resistance, INR going up to 13 and still the patient warfarin dose going up to 13 and INR is still 1. That is again an issue. And we cannot use DOAC as per the recommendation and whatever evidence we have. And higher INR is not always better. There is always risk of bleeding. And in case of refractory and non-criteria APS, suspicion is important and we have to try experimental therapies without evidence. And even we don't know how to proceed with the seronegative APS patient. One time positive, second time positive, and somebody is repeating third time that is negative, again testing negative. So what to do with this patient where they are zero converting from positive to negative during follow-up? That also we don't have evidence. So the people are telling we have to manage like the APS, even if it is zero converted to negative state. So thank you.
Yeah. So thank you, Dr. Ilasul. Such a excellent and insightful presentation. There are plenty of questions which are pending for you. So we'll get into it first. So how to diagnose and prove seronegative APLA syndrome? Do you regularly test for non-APLA antibodies?
Usually, in case of if we have strong suspicion and there is obstetric complication that is strongly point towards APS, usually I will go with the anti-annexin and anti-PSP.
Okay. Uh, Anti-annexin is not available everywhere. PSPT, Lalpath, and some labs are doing now.
Yeah, CMC is doing, I think.
Yeah, CMC is doing. Uh, Regarding treatment of APS nephropathy, you have covered. Is there any role of immunosuppression in APS nephropathy?
Yeah, if initially it is anticoagulation only, but the problem is that the pathogenesis also involve complement and inflammation. So if patient is refractory to anticoagulation alone, always you have to start immunosuppression.
Uh, how do you manage when a lady is APLA syndrome and has a history of two first trimester abortion only, two more than three first trimester abortion present, but triple antibody negative? Should we test for other antibodies? Yeah, that is what seronegative APS
So
means.
pregnancy, you will not take risk. If patient is again pregnant, you start aspirin and heparin because it's precious. You have to consider it as seronegative obstetric APS and treat it like that.
Yes. Role of HCQS in primary APS you have covered almost. Why are DOACs not effective in APLA syndrome? Can we diagnose seronegative catastrophic APLA syndrome? These are DOACs
Yeah,
you
it's
have covered.
everything is individualized and your clinical suspicion. If you are
Yes.
thinking it's like strongly towards APS, you manage like APS. There is no harm in that.
Okay. And when IVIG itself has a thrombotic risk, why it is given in catastrophic APLA?
Because there is other factors more than IVIG that is lead to thrombosis. That is
Yes,
important.
yes, yes. And sometimes in thrombotic APS, patients, despite giving warfarin or acetron, they don't build up their INR. Yeah, despite of whatever measure you take, all the precautionary things you explain them, they are not able to build the INR to 2.5. There, do you consider the DOAC should be given if they are not at all building the?
No, don't give drugs. That's why I told if patient is not manifesting with any thrombotic episode, you can try increasing this unless it lead to like small bleeding. And better is always like put change it to heparin or normal long term heparin if it is
Long
not
term.
getting. Yeah.
Yeah. Okay. Okay. And think we are over with the question. Uh, any specific reason why repeat testing done at exactly 12 week apart after 12 week?
Because usually there is a saying if you have an acute thrombotic episode, that itself can lead to factor VIII or
Yeah.
CRP elevation that will alter this. So there's no reason like 12 weeks, but it's basically for to make sure that there is no other things that is altering your testing, like your CRP or factor VIII or drugs or stress
Yeah. Yeah. So possibility all those confounding factor would normalize and
to avoid that only.
yeah. Okay. Yes. I think we are over with the question, and this was a very lucid presentation by you and very in depth. So I think I'll end the today's scientific session, and I'll thank Dr. Ilasul for such a lucid and valuable presentation, along with Dr. Neena Chitnis ma'am and Salil Ganu for his moderation the session, and Dr. Nayantara who had presented excellent case today. So thank you all, and thank you for this interactive discussion. We can close. Okay.
Okay, thank
Yeah.
you so much for patience.